So, why is fluid prescribing an issue? Well, the CPOD, that's the National Confidential Inquiry into Patient Outcome and Death, have identified inappropriate intravenous fluid prescribing as a source of excess morbidity and mortality repeatedly since 1999. We're not very good at it, and we haven't got much better at it over the last 15 years. Poor fluid prescribing can give our patients arrhythmias, edema, both pulmonary and peripheral, and other complications associated with electrolyte abnormalities. There's some core knowledge that it's vital to know in order to prescribe safely. What's in the basic fluids? So-called normal saline has a huge quantity of sodium chloride in it. Hartmann's is a little more balanced with noticeably less chloride. And 4% dextrose in 0.18% saline contains only 31 millimoles per litre of sodium and chloride ions. The National Institute of Clinical Excellence published some guidelines to try and help the problem in 2013. These classify IV fluids into resuscitation, routine maintenance, and therapy for replacement or redistribution issues. First, you have to assess your patient using an ABCDE approach. If they qualify for fluid resuscitation, an initial bolus of 500 ml 0.9% saline or Hartmann solution over less than 15 minutes is recommended. As soon as that's in, reassess the patient using an ABCDE approach. If they require further resuscitation, give boluses of 250 to 500 ml 0.9% saline or Hartmann's, again over less than 15 minutes per bolus. As always, reassess the patient following each bolus. If your patient has needed 2 litres or more of fluid resuscitation, it's time to call for some expert help. Don't forget to document everything thoroughly. Remember, if it wasn't documented, it wasn't done. So that's fluid resus. But what about if your patient is stable? Well, now's the time to gather more information including their history, comorbidities, clinical examination, observations, and further investigations such as use and ease. Following that, ask yourself, can they meet their requirements orally? If the answer is yes, hooray, you're done! Encourage them to eat and drink normally. If they're nil by mouth or have poor oral intake, but are otherwise reasonably fit, they may require routine maintenance alone. The initial prescription should aim to include 1 millimole per kilo per day of sodium, chloride and potassium in 25 to 30 ml per kilo per day of fluid. If they're nil by mouth, they should also get 50 to 100 grams per day of glucose to ward off starvation ketosis. Daily monitoring is essential and should include a full clinical assessment with examinations of fluid balance and urine output, daily use and ease, and you might consider serial weight measurements. Ideal urine output is at least half a ml per kilo per hour for most patients. Let's go through a worked example. A 70 kilo nil by mouth patient will require 70 millimoles of sodium, potassium and chloride in 1.75 to 2.1 litres of fluid with 50 to 100 grams of glucose per day. NICE recommends 4% dextrose and 0.18% saline for initial maintenance prescriptions. Taking this advice, we could consider prescribing 1 litre with 40 millimoles of potassium and a second litre with 20 millimoles of potassium to make up the first day's prescription. This would be slightly low on sodium and potassium, but would be close to our daily targets, and it's worth bearing in mind that it's much easier to give more of something that's too low than to take back something we've given too much of. Alternatively, we could consider 500 ml of 0.9% saline with 20 millimoles of potassium, followed by a litre and a half of 5% dextrose with 40 millimoles of potassium. Again, this is close to our daily targets, however notice the increased chloride load from this regime. This becomes increasingly problematic in heavier patients. A similar prescription using Hartmann's instead of 0.9% saline has a much smaller chloride load. Okay, so what if our patient doesn't require fluid resuscitation but is too sick for routine maintenance alone? This is where we start using fluids as therapy for replacement and redistribution issues. These include our patients with dehydration, fluid overload, or potassium abnormalities, our patients with abnormal GI losses, blood loss, or polyuria, for which this diagram can help estimate requirements, and our patients with severe sepsis, sodium abnormalities, organ failure, refeeding syndrome, and post-operative fluid retention. Appropriate prescribing in these situations involves estimating the patient's additional fluid and electrolyte needs and prescribing them on top of what they should receive for a routine maintenance prescription. Don't forget to document what you've prescribed clearly so that an F1 called to write up fluids for your patient in the middle of the night can clearly see your reasoning and what you want prescribed. All of this information is available in the NICE algorithm if you ever want a reminder. Thanks for watching. Prescribe safely.